Welcome you to the lecture on autoimmune diseases part 2. Autoimmune diseases can silently turn your own defenses against you. Today, we are uncovering the hidden battles inside the body, from joints to glands and even your kidney. Without further delays, let's get started. What if your skin and organs slowly stiffened from the inside out? That is the hidden threat of scleroderma. In scleroderma, the anti-centromere antibodies are the hallmark diagnostic marker for limited cutaneous systemic sclerosis. Scleroderma can be either a limited, that is cutaneous systemic sclerosis, or diffuse. So let's focus with the cutaneous scleroderma, that is known as the CREST syndrome. In CREST syndrome, the C stands for calcinosis cutis, R Raynaud's phenomenon, E esophageal dysmotility, S sclerodactyly, and T for telangiectasia. The hallmark antibodies are the anti-centromere antibodies. I have a clue for you. The CREST is limited type. It is not that a diffuse type. So limited, it is limited within the center. You can remember something like that to remind you that the anti-centromere antibodies are positive for CREST syndrome. The pulmonary complications such as pulmonary fibrosis that leads to pulmonary hypertension can occur in both limited sclerosis as well as in diffuse type systemic sclerosis. In the diffuse type systemic sclerosis, the diagnostic antibody is anti-topoisomerase, while we saw that in the limited type it is anti-centromere. What is diffuse? What else it affects? Apart from the limited type findings, it also presents with more severe systemic involvement and skin thickening. It causes malignant hypertension due to renal involvement, causing surge of renin, angiotensin, aldosterone system. So all the systemic findings can be seen in diffuse type systemic sclerosis. Primary biliary cirrhosis. The tiny bile duct can trigger a big autoimmune attack. So that is primary biliary sclerosing disease. In primary biliary cirrhosis, it typically affects the women aged 20 to 50 where the bile ducts are affected. Here, because of the bile duct being affected, there is an obstruction which will be obvious with elevated alkaline phosphatase, direct bilirubin, as well as increased serum cholesterol. The antibody is the anti-mitochondrial antibodies. They are pathognomic for primary biliary cirrhosis. Because of the obstruction and because of the elevation of the direct bilirubin, generalized pruritus is the most common presenting feature. This is an autoimmune disease. This often presents with in association with other autoimmune diseases in the family, like rheumatoid arthritis in the brother, or SLE in an aunt, or something like that is a possibility. Autoimmune hepatitis. Sometimes our own liver becomes the target of our own immune system. Autoimmune hepatitis reveals the silent war that is present within. So how will it present? What is the problem? Here it typically presents in women 20s to 30s with unexplained elevation of hepatic transaminases, that is AST and ALT. Why? Because of the antibody which is attacking the liver cells with an elevation of hepatic transaminases. This will result in an increase of anti-smooth muscle antibodies. This is mostly a diagnosis of exclusion because we must eliminate other causes of hepatitis such as viral hepatitis, drug-induced liver disease, and other causes. Rheumatoid arthritis. When your immune system mistakes your joints for enemies, then what happens? Stiffness and the pain will take over. That is rheumatoid arthritis. The most common presenting feature is arthritic joint stiffness and pain. The two important antibodies are the rheumatoid factor, where rheumatoid factor is an IgM antibody directed against the Fc region of the IgG. And we have the anti-CCP antibodies, which is anti-cyclic citrullinated peptide antibodies, which are more specific for rheumatoid factor more specific than rheumatoid factor for rheumatoid arthritis diagnosis. Sjogren syndrome. Ever wonder why dry eyes and mouth could signal more than dehydration? It can be due to Sjogren syndrome, the secret autoimmune culprit. Here we have anti-SSA, anti-Rho and anti-SSB antibodies. With the classic triad, they can have a dry mouth xerostomia, dry eyes xerophthalmia and arthritis. In Graves' disease, it is mostly because of increased thyroid production because of the antibodies which direct against the TSH receptor. So anti-TSH receptor activates the TSH. Anti-TSH receptor antibodies will activate the TSH receptor. So this is the common cause of hyperthyroidism. So for starters, you might think that when the antibody is targeting the TSH receptor, then the receptor is supposed to get deactivated, right? But that's not so. It will activate the TSH receptor, thereby resulting in hyperthyroidism. And the key features apart from the regular hyperthyroidism features are the exophthalmos and pretibial myxedema. What happens when the body quietly sabotages its own thyroid? So that is the Hashimoto's disease. In Hashimoto's disease, they will be having a typical hypothyroid features because there are antibodies against thyroperoxidase and thyroglobulin. So why do we need thyroperoxidase and thyroglobulin? They are the enzymes and the molecules that are very much important for thyroid formation. So I will make a video about the thyroid formation. So when the antibodies against the antithyroperoxidase and antithyroglobulin are there, then it results in Hashimoto thyroiditis. So they will be presenting with the typical hypothyroid features like bradycardia, menstrual irregularities, depression, carpal tunnel syndrome, elevated cholesterol, proximal muscle weakness with elevated CK. In addition, in the Hashimoto's thyroiditis, the pathognomic finding is a lymphocytic infiltrate. Pernicious anemia. Vitamin B12 deficiency isn't always dietary. Sometimes the immune system can be the real culprit. Why? For the vitamin B12 to get absorbed, we need the intrinsic factor. The intrinsic factor will be produced by the parietal cells. When the antibody targets that parietal cell or the intrinsic factor, then it results in vitamin B12 deficiency. Thereby, the vitamin B12 absorption is essential in the terminal ileum. Vitamin B12 deficiency will present with megaloblastic anemia with neurological complications like peripheral neuropathy, subacute combined degeneration. Celiac disease. Gluten isn't just a dietary villain. The immune system can turn it into a full-blown intestinal attack in celiac disease. In celiac disease, there are two antibodies that are diagnostic. Anti-endomysial, that is the anti-gliadin, which is the gliadin is the protein which is present in the gluten. So we have antibodies against that. And anti-tissue transglutaminase IgA antibody. So they both are diagnostic for celiac disease. So wherever the gluten is present, they will be presenting with it will trigger the inflammatory response. So where will the gluten be increased? It will be increased in wheat, oats, rye and barley. Gluten is a content in all these substances. So in these can trigger the inflammatory response and therefore the celiac disease. The pathognomic finding is duodenal biopsy will show flattening of the intestinal villi. And since the intestinal villi cannot absorb properly in celiac disease, they will often present along with iron deficiency anemia. Type 1 diabetes mellitus. What if the pancreas is under siege by its own defenses? That is the story of type 1 diabetes mellitus. Against the pancreas, we have anti-glutamic acid decarboxylase, anti-GAD antibodies, which will target the pancreatic beta cell enzymes. And anti-zinc transporter 8 antibodies will also target the beta cells. So all these will indicate autoimmune destruction of the pancreatic beta cells leading to absolute insulin deficiency. Primary membranous glomerulonephritis. The kidneys filter silently, but in membranous glomerulonephritis, the immune system quietly leaks havoc. So what happens? The antiphospholipase A2 receptor antibodies are specific for primary membranous glomerulonephritis. Here, the membranous glomerulonephritis is a nephrotic syndrome with proteinuria, hypoalbuminemia, edema, and hyperlipidemia. The other causes of membranous glomerulonephritis can be cold salts, dapsone, sulfonamides, rheumatoid arthritis, and malignancy, and sometimes even hepatitis B. Thrombotic thrombocytopenic purpura. Here thrombotic thrombocytopenic, there is a thrombus. With the name you will know that there is a thrombus which is formed and it is associated with decreased platelets, thrombocytopenia, and it presents with the purpura. What is the reason behind the thrombus? The thrombus is supposed to be cleaved, so we have an antibody against the cleavage, and that is the anti-ADAM TS13. It is the matrix metalloproteinase that cleaves the thrombus, that is, that cleaves the 1 Willebrand factor multimers. So when the antibody is produced against it, the cleavage of the thrombus doesn't happen and it results in consumption of the platelets, leading to thrombocytopenia. Since the cleavage doesn't happen, it is resulting in a thrombosis. So in thrombosis is due to the cleavage doesn't happen. Thrombocytopenia is because of platelet consumption, and because of the platelet consumption and the thrombosis that is formed, it will lead to microangiopathic hemolytic anemia. What will it happen? It will result in renal issues, hematuria or elevated renal function test. It can result in confusion, seizures, focal deficits because of cerebral infarction. And this thrombosis can also result in widespread systemic inflammation resulting in fever. Let's see what happens in the similar condition, immune thrombocytopenic purpura. Again, here there is thrombocytopenia similar to the previous condition, but here the mechanism is entirely different, that is immune. So what is immune and why do we have thrombocytopenia? The antibodies target the GP2B3A receptors. So there are anti-GP2B3A antibodies which will target the platelet surface receptors, causing platelet destruction and impaired aggregation. So why does this occur? It occurs idiopathically. So it is called as ITP, where the I stands for immune thrombocytopenic purpura, or the I also stands for idiopathic thrombocytopenic purpura. This will present in a school-age children with petechiae and nosebleeds following a viral infection or even idiopathically. So, or this can even present in adults, in women aged 30 to 40s with prolonged bleeding time and decreased platelet count. This is the chronic ITP pattern, and that which is seen following a viral infection is the acute ITP pattern. Heparin-induced thrombocytopenia. In heparin-induced thrombocytopenia, after the heparin is administered, it has to get neutralized by the platelet factor 4. This is what happens normally. But when there is antiplatelet factor 4 heparin complex, that is when there is antibodies against the complex of heparin and platelet factor 4, then it produces the condition known as HIT, that is heparin-induced thrombocytopenia. First, the problem is there will be the thrombus which is formed because of this reaction. What is the problem over here? The patient is receiving heparin because he or she is already suffering from a thrombus condition, like a platelet pulmonary embolism or a deep venous thrombosis. So in the treatment for that is heparin. Now on providing heparin, when there is dangerous paradoxical reaction, because heparin itself or the HIT condition caused by heparin itself is resulting in a thrombus react condition. This is the first problem. The second one is the HIT can present with thrombocytopenia, decreased platelets. Why? Because the antibodies against platelet factor 4 heparin complex can be directed against the platelets and it can result in thrombocytopenia. Or the platelets can be consumed in this microthrombi which are formed from this complex. So it can be because of both the reasons. What is the treatment in HIT? Can warfarin be given? No. Warfarin is contraindicated in HIT. But direct thrombin inhibitors like dabigatran can be given. Why? For this we need to know about the um, um, blood coagulation cascade. Thrombin is the one which is necessary to form the thrombus. What is the role of heparin to decrease the thrombus formation? It will activate the antithrombin. What is the role of dabigatran? It will directly inhibit the thrombin. So once directly the thrombin is been inhibited, then that is the treatment for HIT. In Addison's disease, there is an adrenal destruction. So why? Addison's disease is adrenal destruction. So autoimmune Addison's disease is due to anti-21 hydroxylase antibodies. 21 hydroxylase is an important enzyme in the formation of the adrenal hormones. So when we have antibodies against anti-21 hydroxylase, then there is autoimmune adrenal destruction. So hyperpigmentation is also a classical finding which is due to elevated ACTH. In the first place, why should ACTH be elevated? When the adrenals don't produce the hormones, then as a decreased negative feedback, the ACTH is elevated. ACTH will also increase the MSH, melanocyte stimulating hormone. The melanocyte stimulating hormone will stimulate the melanocytes, resulting in hyperpigmentation. In addition to it, there is a mineralocorticoid deficiency. That is the aldosterone deficiency. Aldosterone is needed to increase the sodium and decrease the potassium. When aldosterone is deficient, sodium is decreased and potassium is increased. When the potassium is increased, it is generally associated with increase of hydrogen ions, that is metabolic acidosis. Increased hydrogen ions will be reflected as low pH. This is what is seen in Addison's disease. Rheumatic heart disease. In rheumatic heart disease, there is anti-myosin and anti-valve antibodies against group A streptococcal M protein. So these antibodies are directed against group A streptococci, but it cross reacts with the mitral valve through molecular mimicry. This cross reaction is known as type 2 hypersensitivity. When this cross reacts, it will affect the valve, and early stages it will be presenting with early mitral regurgitation progressing to late mitral stenosis, because valve scarring and calcification will develop over time. In addition to antibodies against the valve, the antibodies are also directed against the basal ganglia, resulting in Sydenham's chorea and the skin lesions manifesting as erythema marginatum. What about neuromyelitis optica, also known as Devic syndrome? Here, the presentation will be similar to multiple sclerosis, but this will present with optic neuritis and transverse myelitis also. Why? What is the problem? The problem over here is there are anti-aquaporin 4 antibodies. Aquaporin 4 is that which is present on the supporting cells such as astrocytes, thereby maintaining the water balance in the astrocytes. When the anti-aquaporin 4 antibodies are directed against the aquaporin in the astrocytes are affected. With the astrocyte being affected, they are the supporting tissue in the nervous system. So they will be supporting the oligodendrocytes. Without these oligodendrocytes, without the supporting system such as astrocytes, the oligodendrocytes cannot perform properly. Therefore, the oligodendrocytes will not be able to myelinate the neurons. That is the function of the oligodendrocytes. Since the myelination doesn't happen, it will present as similar to multiple sclerosis, where again the myelination of the central nervous system is the issue. In addition, in neuromyelitis optica, it will also present with optic neuritis and a transverse myelitis as the predominant features. If that is difficult, just remember at least optic neuritis associated with the multiple sclerosis is neuromyelitis optica. In multiple sclerosis, there is IgG oligoclonal bands because the pathology is entirely different in multiple sclerosis. But here, since the pathology is anti-aquaporin 4 antibodies, the CSF will be negative for IgG oligoclonal bands. In this way, we can distinguish multiple sclerosis and neuromyelitis optica. Let's see what happens in autoimmune hemolytic anemia. As the name says, there is hemolysis, that is the lysis of the RBCs because of autoimmune antibodies. So these autoimmune antibodies, because it is lysing the RBCs, they will be presenting with anemia. The autoimmune antibodies can be either IgM or IgG. When it is IgM, it is cold autoimmune hemolytic anemia, and when it is IgG antibodies against RBCs, it is warm. There is a clue to remember this. If you know some basics of Hindi like me, G stands for garam. Garam is hot in Hindi. So G and warm autoimmune hemolytic anemia. In this way, we can remember it. So, what are the reasons for warm autoimmune hemolytic anemia? That is IgG antibodies against RBCs. It can be caused by drugs, it can be caused by infections, and it is associated with chronic lymphocytic leukemia. Both IgG as well as IgM, the both cold and warm autoimmune hemolytic anemia shows positive Coombs test. What about cold autoimmune hemolytic anemia? Here the IgM antibodies against RBCs. So the main reason are the cytomegalovirus as well as the mycoplasma. Positive Coombs test is present over here too. With this, we have come to the end of the presentation about autoimmune diseases part 2. I have just given you a gist about everything. So this will be useful if you are preparing, if you want to know the entire detail in the entire crux of the details. So I have some good news. I'm starting my mentoring lessons for medical graduates and USMLE aspirants. If you like to get mentored by me, you can send me a message. I am Dr. Veena with a passion for teaching. Have a good day. All the best to whatever exams you are appearing.